Hello and welcome back to the Ophthalmic Referrals series. My name is Christian, I'm an optometrist, and the aim of this series is to offer some helpful hints and tips to my optometry colleagues in primary care who are making referrals to ophthalmology. This second talk in the series will focus on glaucoma referrals. And I would encourage you to watch the first talk in the series where we cover the generic information that would be included in any ophthalmology referral, as that will underpin all the subsequent talks in this series. And I'd also remind you that this is how I would go about referring a glaucoma patient, but you must of course use your own professional judgment and follow any protocols and guidance in effect. No talk on glaucoma referrals would be complete without reference to NICE NG81. The guidance does make it clear that there are a number of tests which should be conducted before referring to secondary care. And it does make it clear that these are separate from a sight test. It talks about repeating fields and IOP on another occasion unless there's good reason not to do so. And they also give us some scenarios where we definitely should be referring a patient. And if we are referring, then it says we should provide the results of all the examinations and tests with the referral. So let's start off with the basics. We need a cup disc ratio for each eye. We need an intraocular pressure measurement for each eye with the method used. For the visual fields, we ideally want those to be attached. If not, we want them to be described as reliable and full. And we also want to have an idea of the limbal anterior chamber depth. So using the Van Herrick, we can grade them from 0 to 4, or better still using a percentage. What do we want to avoid in our glaucoma referrals? Well, describing a disc as suspicious without providing a cup disc ratio or any other description is ambiguous and not that helpful. Describing the IOP as high but without actually providing the intraocular pressure measurement is not helpful, because 24 is high but so is 64, and I think you'll agree that they'd be managed in quite different ways. It's fine to include a corrected intraocular pressure, but it is also important, more important, to include the raw IOP data. Make it clear which is the raw data and which is the corrected IOP. Saying that somebody has a field defect is not that helpful. Is that just a single point of reduced sensitivity, or is it a dense arcuate defect? Or indeed is it a neurological field defect which is unrelated to glaucoma? And describing the angles as open or narrow is much less helpful than giving a Van Herrick grading. So once we've got the basics right, you may wish then to upgrade the quality of your referral further. As far as the discs are concerned, you may want to include the vertical disc diameter. As you know, a large cup in a large disc is less concerning than a large cup in a small disc. Are there any notches in the neuroretinal rim or any hemorrhages in or around the disc? Do you have previous cup disc data? Although inter and intra observer variability may be high, if there's a significant change in the cup disc ratio over time, that does suggest progression. For intraocular pressure, we're going to be thinking more in terms of contact methods, Goldman being the gold standard and the time. And for visual fields, I'd always encourage you to attach your visual field plots even if they're normal, and making a description of the reliability as well as any defect. As far as the anterior chamber is concerned, we've talked about Van Herrick. Gonioscopy is obviously the gold standard. And if it's a technique you're not particularly familiar with, I'd encourage you to have a look at gonioscopy.org. There's lots of free helpful information on there. And as far as the central anterior chamber depth is concerned, we can use Smith's technique, which is actually quite simple, and it's very helpful, particularly in cases of potentially narrow angles. Do you include the risk factors? Is there a family history of glaucoma? Are the corneas thin, or any poor circulation? And as far as imaging is concerned, disc photos, OCT scans of the disc, circupapillary RNFL and ganglion cell complex are all very helpful. Returning to progression, if you have any historic field plots, historic photos, historic OCT scans, very helpful to include them, because that can really help to evidence whether there's stability or progression. So that concludes the talk on glaucoma referrals, which I hope you found helpful. Next time I aim to cover cataract referrals. Do please include any comments or feedback in the box below, and if these talks are well received, then we can continue with the series. Thank you.